Audio Jungle. This is our series on improving outcomes in intracerebral hemorrhage. Stryker is proud to support the American Heart Association's Hemorrhagic Stroke Surgical Quality Improvement Initiative. The recommendations and opinions represented by our guest speakers may not represent the official position of the American Heart Association, American Stroke Association. The materials are for educational purposes only, and do not constitute an endorsement or instruction by the American Heart Association, American Stroke Association. The American Heart Association, American Stroke Association does not endorse any product or device.
Welcome to Heartbeats from Lifelong Learning and our series on intracerebral hemorrhage, or ICH. I'm Ana Lucia Garcia Warniz. I'm a stroke neurologist at Rhode Island Hospital and an assistant professor in neurology at Brown University. And joining me is Dr. Joshua Goldstein. He's an emergency physician who specializes in neurological emergencies and a professor of emergency medicine at Harvard Medical School.
Thank you so much for having me today.
And Dr. Wendy Siaye, she's a neurologist specialized in neurocritical care and a professor of neurology at Johns Hopkins Medical School. Welcome.
Thank you also for having me.
Great. So today, we're going to talk about a real life case. I would like to hear about your opinions. We have a 71-year-old gentleman, previously independent, with a history of atrial fibrillation on home anticoagulation, apixaban. He presents with acute onset of left hemi-body weakness. He has been experiencing headache for the past 4 hours of moderate to severe intensity and acute onset at the time of the left-sided weakness. So he presents to an emergency department. On arrival, his vital signs show hypertension with a systolic blood pressure of 195 over 110. The finger stick is 142. His platelets are normal at 350, and the creatinine is also normal at 0.5. His exam is notable for somnolence. He has a right visual field defect, a mild to moderate left-sided weakness, sensory loss and neglect. So his NIH stroke scale is a 9 and his Glasgow coma scale is 13. Dr. Goldstein, how do you approach this case as an emergency physician?
Well, first of all, these initial symptoms certainly sound like some sort of a stroke and should be treated like a stroke of some sort. This patient's clearly having an acute neurologic event. And it's within this acute phase. For many centers, this would sort of be activate a stroke system. Is certainly in my center as well. And we don't even know whether it's ischemic or hemorrhagic. Now, things that would make us particularly think about a hemorrhagic stroke would be, for example, headache. It's less common in ischemia. It's more common in ICH. Sudden onset of headache could make you even more worried for subarachnoid hemorrhage. The fact that he's on an anticoagulant, like apixaban, these are great at preventing ischemia, but known side effects is a bleeding event, such as ICH. And so these are things I'd think about it. If he were having vomiting, seizure, or sudden altered mental status, I'd also think about hemorrhage. So the main approach for emergency medicine is first, this patient needs rapid imaging. Now, you do want the ABCs, airway, breathing, circulation. It sounds like this patient is awake and talking. You've given me enough information to say that this patient was probably cooperating with your exam a bit. Ideally, EMS saw this patient and got the initial finger stick and initial exam. So I could meet this patient in registration or triage and just go straight to the scanner. But even if the patient arrives, we could do that as well. So what I would do with this patient is meet them at our registration desk, call out a code stroke, and send EMS and the patient straight to CT, but knowing we'll sort out more details, including his neuroexam after the scan. And last, I'll say, if you work at a hospital where ICH patients or severe stroke patients need to be transported, you could consider asking your EMS team to stick around while you wait to see if this patient needs to go somewhere else, save you the trouble of calling somebody back in to transport the patient.
That's great. So indeed, that's what happened. The patient got a code stroke, as you pointed out, had acute neurological symptoms, got a non-contrast head CT, and it showed a large right parietal hemorrhage. It was a 50 milliliters hemorrhage of 6 by 4 by 3.9. Dr. Siaye, this is for you. What do you think about this case so far with the ICH? What would the differential be for you?
Yes, absolutely. So there's a broad differential. About 85% of spontaneous ICH, which this appears to be, it doesn't appear to be traumatic, is not attributable to an obvious etiology and is usually attributed to cerebral small vessel diseases, which are arteriolosclerosis and cerebral amyloid angiopathy. And arteriolosclerosis typically causes hemorrhage in any location, but often causes deep hemorrhages, is related to lipohyalinosis in the arterioles due to hypertension predominantly. And CAA, or cerebral amyloid angiopathy, is due to deposition of amyloid in the cortical and leptomeningeal blood vessels. And so it causes strictly lobar and cerebellar hemorrhages, but not deep hemorrhages, although patients can have both types of pathology. Now, there are a vast number of macrovascular or other etiologies. So typically, we want to look at, first of all, location of the hemorrhage. Is it deep or lobar? And even is it primary intraventricular hemorrhage, which has another differential to it. Sometimes patients can have severe hemorrhages due to end-stage renal disease, due to chronic uremia and complications of hemodialysis. And I'm showing a case of that on this particular slide. And of course, hemorrhagic transformation of an ischemic stroke also needs to be ruled out, especially if a patient is post-thrombectomy, of course. We need to differentiate between hemorrhagic transformation and contrast extravasation with a dual energy CT, but that's a different sort of scenario. Aneurysmal subarachnoid hemorrhage can present with parenchymal hemorrhages, and in this case that I'm showing, a primary intraventricular hemorrhage caused by a left pica aneurysm. Patients can rarely present with a hematoma secondary to reversible cerebral vasoconstriction syndrome, or RCVS, which affects the small and medium-sized arterioles in the brain. Traumatic brain injury can cause strict hemorrhages, often located in the anterior temporal and the anterior frontal lobe due to hemorrhagic contusions. And cerebral venous sinus thrombosis should always be considered, and this can cause hemorrhage due to venous infarction. Other vascular malformations which need to be ruled out with CTA or diagnostic angiography or MRI include dural AV fistulas, cavernomas, and arteriovenous malformations. And finally, malignant tumors can also present with hemorrhage, and of course, an MRI is needed to look for rim-enhancing lesions and multiple lesions.
Wonderful, thank you. That's a great differential. So far we know this patient has a lobar hemorrhage in part of the differential that you addressed. So Dr. Goldstein, as an emergency physician, what is your approach for patients like this coming with an intracranial hemorrhage?
So luckily, we learn pretty quickly that it's a hemorrhage at our place. At my hospital, we have radiology that gives us an immediate read in the scanner. There are many other hospitals where they might have a rapid detection software or an AI software that pings somebody where there's a hemorrhage. At other hospitals where you might have to wait for a radiology read or nobody quite looks at it, you might have to wait a little bit. But hopefully you've learned pretty quick that this is a hemorrhage. Patient comes back to a room. We think about what do we need to do. Now, there's great data from clinical trials, such as INTERACT-3, and other studies that look at bundles of care, that if we give certain good bundles of high quality medical care done early and done well, improves outcomes. And so we should do that. And these are things that you don't have to be a neurosurgeon to do. You don't have to be one of these brilliant stroke neurologists or neurointensivists to do, that those of us on the front lines all can do. And so I'll walk through those a little bit. The key thing is to have your institution have a system, ideally some computerized order entry set, where you click the ICH button and it launches all the things that tells the physician what to do and the nurse what to do and the pharmacist what to do. And so everybody has a sort of a clean, like, this is our standard protocol. Airway, of course, for some of these folks have terrible mental status, can't protect their airway. So you might have to think about intubating them early, either now or for the transport, if you think they aren't stable for transport, if they need to be transferred somewhere. But if you don't need to intubate them, please don't, right? Because we want them to have to be able to follow their neuro exam. Blood pressure control. There's a lot of studies saying early blood pressure lowering is good. This patient's blood pressure was quite high when he arrived. We would have left it alone if it was an ischemic stroke, but now that we know it's a hemorrhage, we can and should bring it down. The AHA goals are to aim for a goal between 130 and 150 millimeters of mercury. So start a rapid acting agent. Consider maybe using a drip right off the bat so you can carefully control the blood pressure, or just start with a bolus of something so you can get things going. Lowering too much is bad. Maybe more than 60 millimeters of mercury might be bad. So having some parameters around lowering is a good approach. For anticoagulation reversal, this patient's on a blood thinner. and you're worried that that's contributing to the bleeding. And so what do you do to reverse it? Patients like this are at high risk of expansion. The highest risk expanders are those who are presenting early into their course, like this patient is, and those who are most recently since their last dose. We don't actually know when this patient's last dose is at the moment. First thing is go get that information from the family, from the patient if you can. Some places you can check a level, a lot of places can't. But if you can't prove otherwise, you should consider reversing them. There was an agent that was FDA approved called andexanet. That agent had been available, however, it is no longer on the market. So for most people, they would use the alternate prothrombin complex concentrate, or PCCs, for anticoagulation reversal. And let's do the basics. This person's blood glucose was a little bit high. Some people would blow that off. But again, as part of our bundle of care, treat hyperglycemia, check their temperature. If they're febrile, treat that. Fever is bad for stroke and ICH. Hyperglycemia is bad too. These are the basics. It's easy to get caught up in sort of overcomplicating things. And last, consults. At our institution, we would call both neurology and neurosurgery for these folks. And wherever you are, there should be some sort of clear who to call for ICH. Again, call them early in parallel with all this stuff, because they'll give you early recommendations for management and start planning for your next step.
That's a wonderful thinking process of how we should treat this patient from the beginning as an emergency physician and then as a consultant for ourselves. So it sounds like you could potentially be thinking about involving neurosurgery and concerned about situations where we may have to involve our colleagues for that. Dr. Siai, could you tell our audience which patients with an intracranial hemorrhage are usually considered for surgery?
Sure. So let's start out with the 2022 ICH guideline from the American Heart Association, which did have some recommendations for supratentorial hemorrhage, which is what this patient has, and for minimally invasive surgery. And this was before the trials called Enrich and Mind had been published. And so there was no sort of detail about location of hemorrhages or timing of surgery. But the guideline basically said that for supratentorial hemorrhages, a volume greater than 20 to 30 milliliters and a Glasgow Coma scale of 5 to 12, that minimally invasive surgery for ICH could be useful to improve mortality, but the effect on functional outcome was uncertain. And possibly that minimally invasive surgery could potentially be better than craniotomy for improving functional outcomes. There was also a guideline for craniotomy for supratentorial hemorrhage, but basically it stated that the usefulness of craniotomy for functional outcome or mortality improvement is uncertain, and that craniotomy might only be useful for a life-saving procedure. So here we are in 2025, and we now have a number of devices for minimally invasive surgery for supratentorial ICH. And these are, just to mention a few that have been studied in the clinical trials, are stereotactic aspiration with or without thrombolysis, with alteplase, such as studied in the MISTY-3 trial, endoscopic aspiration, which was studied in the MIND trial, and endoport-mediated removal, which was studied in the Enrich trial. And so what I'm showing on the table is a comparison of the 3 recent minimally invasive surgery trials for supratentorial hemorrhage in North America, MISTY-3 with 499 patients, Enrich with 300, and MIND with 236. And note that the MIND study was terminated prematurely. And the time to enrollment for these studies was up to 72 hours in MISTY and MIND and up to 24 hours in the Enrich trial. And the size of hemorrhage that were included were greater than 30 milliliters in MISTY and Enrich and greater than 20 milliliters in the MIND trial. So all fairly similar. And the GCS criteria were all the same, 5 to 14. And everybody had to have a premorbid modified Rankin scale of 0 or 1. So they couldn't be previously impaired. They all had to come in within 24 hours of their symptom onset. So I'm just going to briefly talk about each trial and where that has taken us in terms of the typical patient for surgery nowadays. You're going to hear a lot more about these trials in future podcasts. So MISTY-3, which used stereotactic thrombolysis, was neutral on its primary outcome of a good modified Rankin scale at 1 year, which was not different between medical management alone and surgery, but it showed a significant reduction in mortality at 1 year with about a 6% benefit in favor of surgery. The MISTY-3 trial also showed us that if the surgeon could achieve less than 50 milliliters of residual end of treatment volume, then those patients had both a lower mortality and a better functional outcome at 1 year. The ENRICH trial was a little bit different. It used, for the primary outcome, a utility-weighted modified Rankin scale evaluated at 6 months, and it found superiority in the difference between this mean utility-weighted modified Rankin scale in favor of minimally invasive surgery with the Endoport device. And in the subgroup analysis, or the location analysis, I should say, they found that the lobar location of hemorrhage, which comprised about 70% of the trial population, was the group that benefited, whereas patients who had deep hemorrhages in the anterior basal ganglia did not actually benefit from minimally invasive surgery. Finally, the MIND trial, which had a population of 70% deep and about 30% lobar, was also a neutral trial for the primary outcome of the ordinal modified Rankin scale at 180 days and did not show a mortality difference at any of the time points. So when we talk about which patients are now typically considered for minimally invasive surgery with supratentorial ICH, we should consider obviously no secondary cause of hemorrhage, age up to about 80 years of age, although nobody has really looked beyond that, a Glasgow Coma scale of 5 to 14, NIH stroke scale greater than or equal to 6, lobar location, a volume of 30 to 80 milliliters with less than half of the ventricle having blood, so not too much IVH, and timing within 24 hours of last known well. Now, we can also think about other types of hemorrhages and whether they would be considered for surgery. And so for cerebellar hemorrhage, there is no clinical trial, but patients are sometimes considered for craniotomy if they have neurologic deterioration, brainstem compression, obstructive hydrocephalus, or an ICH volume greater than 15 milliliters in the cerebellum. And this is for a mortality advantage. Next, for intraventricular hemorrhage, if a patient has obstructive hydrocephalus, which is contributing to their decreased level of consciousness, then typically an external ventricular drain will be placed by the neurosurgeon again. And finally, for supratentorial ICH that is very severe and deep, decompressive craniectomy may be considered, with the results coming here from the SWITCH trial, with age up to about 75, Glasgow Coma scale 8 to 13, NIH stroke scale 10 to 30, and this is really for large, deep hemorrhages that have significant midline shift, elevated intracranial pressure that's refractory to medical management, and ICH volume up to 100 milliliters. So those are the types of patients that would be considered for surgery.
Thank you, Dr. Siai. That was a wonderful review of what kind of patients are candidates for that. I think just going back to our case, so the patient was started on nicardipine to lower his blood pressure, as we spoke, as Dr. Goldstein spoke about the blood pressure ranges. He was reversed as well and ended up having a CT angiogram that did not show any vessel abnormality. Within the first 24 hours, he was one of our first patients to actually undergo a minimally invasive surgery procedure. And in the first day, as we're going to see on these slides, he had a good evacuation of the burden of the ICH. And his modified Rankin scale by the time that he left the hospital was a 4. He was ultimately diagnosed with cerebral amyloid angiopathy. And within a couple months, and you'll see on these slides the improvement of his CAT scan, he now has a modified Rankin scale of 2. He's independent. He does have some residual numbness, but just only faint weakness. He stays active. He walks 1 mile a day, and it was a wonderful outcome and one of the first ones that we had out of this new management. So before we go ahead and finish with the last remarks, I just wanted to take up a minute. I think we have some time and would love to hear your thoughts about perhaps blood pressure management on your own institutions. And I don't know if you're more towards the kind of like acute straight blood pressure management, less than 140, of the blood pressure management within less than 160. Would love to hear your thoughts.
Sure. Should I go first?
Yeah, sure. Absolutely.
Yeah. So it depends on who you ask. You know, if our neurosurgeons get back to you first, they want it less than 140 in 3 seconds, and with no bottom number. I think we look at these trials, including the INTERACT-3 trial, including the ATAC-2 trial, a lot of these blood pressure trials that targeted a systolic of less than 140. The people in the intervention group actually hit a systolic of less than 150, right? So whatever benefit you're seeing was achieved by actually hitting less than 150. So the question is, when you're targeting 140, is it because your people are going to hit that, or is that more of an aspirational goal to get it in that direction, knowing they're going to go too far? And I am convinced by some data that going too low too quickly has some downsides. There's some of that signal from ATAC2 and also from some reanalysis of the INTERACT-3 trial. So our institutional guidelines are between 130 and 150, with a goal of achieving that within the first hour, unless you're dropping more than 60 millimeters of mercury. So for example, somebody with a systolic of 250, maybe our goal is not to get down to 130 within 1 hour. That would be our approach.
Wonderful. Thank you. And Dr. Siai, in your institution?
Yeah, I think our approach is probably similar. And again, would depend on the starting baseline blood pressure that the patient comes in with. And also if we happen to know what the patient's baseline blood pressure is, that's always useful. And also the size of the hemorrhage. So if a patient comes in with a blood pressure under 200, and again, we're not going to drop them by more than about 60 millimeters mercury, then 140 is a perfectly reasonable goal. But if a patient comes in with a super elevated blood pressure or has a very large hemorrhage where we know that intracranial pressure is likely elevated and that we're more interested in estimating the cerebral perfusion pressure, which is the MAC minus the intracranial pressure, we may think a little bit about being more liberal with our blood pressure goal. And especially if that patient needs to have hypertonic saline or needs to have other management to deal with intracranial pressure.
Wonderful. Thank you so much for sharing that. So now that we're about to finish, we'd love to hear your takeaway points from ICH. If you could just give our audience like 1 to 2 takeaway points, Dr. Goldstein.
Takeaway point is the most important thing that's going to happen for this hemorrhage patient is before they ever showed up at the door, that your hospital, your emergency department has some system in place and everybody knows what it is. And so your nurses know what you're going to order. Your doctors know what to order. There's some order set that matches your institutional alignment, and that you try to do all the things. The classic one for us emergency physicians, we get easily distracted, looking at all the other things happening, and so it's too easy to think of, call neurosurgery and then go to do another thing. And so the system should be, I ordered all the things to make sure they're happening, and I called the people who needed to be called. And this is still an emergency that we can do something about, and start doing that now.
Dr. Siai, thank you.
Yeah, and I think lots of this gets done in the emergency department, but really underlying etiology of the ICH is super important nowadays, especially diagnosing if the patient has cerebral amyloid angiopathy, much higher recurrence rate, risk for dementia, and so on. So we really want to know about the underlying cause nowadays, and also neurosurgical consultation, really for every hemorrhage, even if you're not sure that this could possibly benefit from surgery. And finally, that the recovery after ICH, especially if it's severe, takes a very long time. And so as you see from these clinical trials, the time period for assessment is different than stroke, which is typically 90 days. The trials for surgery on severe ICH are going out to 6 months to 1 year. And I'm showing this on the last slide from an article that we actually published looking at the patients from the MISTY-3 and the CLEAR-3 trial who had a modified Rankin of 4 or 5 at the day 30 time point, which is similar to this patient who was a modified Rankin of 4 at hospital discharge. And this data showed that of these patients, over 40% of those recovered to a modified Rankin that was favorable, a 0 to 3. And that's similar to this patient who eventually achieved an MRS of 2. So with enough time and rehab, many of these patients can actually achieve a favorable outcome.
Wonderful. Thank you both. And thank you all for participating in this Heartbeats for Lifelong Learning. To get additional information, please visit learn.heart.org. Thank you.